first case of the day. She comes from Chennai and she is a 54 years female. She's postmenopausal. She is a banker. She complains of very progressive kind of a picture that she is going through. Let's join her in her agony to help her and solve her out. Burning discomfort, burning pain in the region which she describes as the lower part, which she holds and shows, is the region of the vagina, introitus, urethra, perineum, the entire area. Her bladder fullness is definitely painful and uncomfortable. This has been progressive for the 5 years. That means what it was in 2015-16 is different from what she is in 2020 during and after the lockdown. She gets now some relief after voiding. She has got dull ache, which happens intermittently in the pelvis, and she has got nocturnal urgency. She stopped sexual activity at the age of 50, 51, all because of something which is related here. So that's the first slide, just to give an idea of a very established woman in her prime of life, who's also a banker and doing well with her work and society. But her own personal grief is that she is going through some agony where she's seeing my colleagues across, and let's help her out. Dr. Shobna, as a gynecologist in Sitapati Hospital and in Chennai with your vast experience, I'm just wondering, let's open up this subject and let's hear your views as a gynecologist, because today we're opening up to gynecologists and understand how is this woman going through and what would be your initial thoughts and processes that you would take up in history and only history.
This is probably a very common presentation. It's just that in all these years in the so-called journey of this particular enigmatic condition, our understanding has definitely improved. And a lot of us have become aware of specific words that the patient uses in her history. In a 54-year-old postmenopausal woman who complains of, difficulty in intercourse and therefore stopped having intercourse and burning sensation, we would normally first think of only urogenital atrophy, and then probably in a busy OPD end up giving her some vaginal estrogen, and there ends the problem. But now with all this awareness about interstitial cystitis, bladder pain syndrome, she has specific symptoms like burning pain in the vagina, urethra, and perineum, and bladder fullness is painful. This is an important symptom that we have come to be aware of. In a recurrent urinary tract infection in urogenital atrophy, they have frequency, but then they have pain during voiding, they have burning sensation during voiding, and overall dryness. Dryness is something that we have to specifically ask for, and if she does not have that kind of dryness and burning sensation while voiding, and there are no associated estrogen deprivation symptoms, and then we have to be aware that this is something else. This is something that is pointing in the direction of something related to the urinary tract, probably interstitial cystitis or painful bladder syndrome. And there the thinking process starts, and that is where the gynecologist has to shift the mindset to something other than the routine UTI and urogenital atrophy, I think.
Wonderful. So yeah, go ahead. Your last sentence on this, yeah, go ahead.
Yeah, do you want me to go on? Because this is the starting point of...
Yeah, got it. So I got what I wanted. I've really got what I wanted. So your opening sentence, Dr. Shobna, was very enthusing. You believe that the jargon and the terminology which the patient uses is so important. And therefore, listening to a patient is more important rather than speaking. We let them just speak. That's good enough for us to know everything that we want to know. Yeah. So I spent decades in Tamil Nadu, so it's fine with me. Yeah. So this was a 54 years. I brought in a 54 years up there, but we know that, Dr. Urmila, can you unmute yourself? Dr. Urmila in Gwalior, Dr. Urmila, can you unmute yourself? We also see women in their late 20s and early 30s.
I can't hear you.
Yeah.
Hello?
Yeah. Can you hear me? Hello? Hello? Am I audible?
Yes, sir, you are audible.
No, I can, yes.
Sorry. So keep,
yes.
Everybody can keep yourself unmuted. Don't worry, we are a small panel. We are letting everybody pitch in as and when required. So Dr. Urmila, coming to you, a similar kind of woman also presents in her late 20s and 30s too. And there is no urinary complaint here. Very important. That means she is a woman who otherwise could have been given UTIs treatment, something which a gynecologist deals very perfectly. So if somebody would be on a much younger age group, in her late 20s and early 30s, which you see, Dr. Urmila, would it be some other thought process now that vaginal atrophy and dryness is not there?
Yes.
Will there be another kind of a thought process in this very case? She's very young. Imagine late 20s, early 30s. Dr. Urmila, can you hear me?
Yes, this bladder fullness that you have excluded is pelvic pain. So pelvic pain in a young girl of this age group, she may be unmarried, but like PID, pelvic inflammatory disease, where our mind goes first. Sex transmitted infections leading to pelvic inflammatory disease. And that is what we must look for by history and by clinical examination and symptomatic relief with the treatment, which does often.
Yes, got it. I wanted to hear that. That's very, very important.
So after excluding.
Yeah.
I think that is most. Yes.
Got it. Completely fine. I'm okay with
because
that.
Urinary problems, you have already excluded. Pregnancy, we already.
Dr. Urmila, you probably on a little wavering kind of your signals, it looks like, for a while. Yeah. So we will just quickly move on this case. I've got it. I completely got it. So I'm just coming on to moving a little faster on the case because we are on time. The catch points in the history here are, and I will come to you, Dr. Shyamla, is that the catch points in this history are, she has got a forced frequency. That means she has got an urge which is painful. I did talk about that just to remind you that she has got some discomfort, some dull ache, and she has got an urgency pain kind of a syndrome. That's the only urinary issue that she has. So if you look at her frequency is more forced by her because of her painful urge. If there is some relief in voiding, does she go more frequently? Yes, still goes 14, 15 times a day. That means she has learned how to live a life. 2 to 3 times at night and she gets up with discomfort only. So her frequency urgency is the only aspect on the urinary side which I'm adding to the continued burning pain, vagina, urethra, introitus area. She also avoids traveling with auto rickshaws, and we heard this lady at 54, and we heard Nilanjana ji speak on this very important, some specific food which in every part of the country they would be avoiding, and she also avoids. So Dr. Shyamla, you want to add something to the whole thing now that we have got positives in the history beyond what we knew in the first slide?
Yes, coming at the catch points, at the outset, you might think it is just overactive bladder. But if you take the history into consideration related to painful urge, there is basically pain when the bladder is getting filled, and she obviously gets some relief on voiding. So we'll have to think in terms of interstitial cystitis,
home, which you're not using for other things, just measure and show us how much you're actually emptying. And also in the frequency volume chart, there's something I do. I just had at the frequency volume chart, I tell them, please mention when you void, why you're voiding. Is it because you're having urgent or you're having pain? So that gives a very clear idea of what is going on. So the frequency volume chart cannot actually on its own tell us whether it is overactive bladder or it is bladder pain syndrome, but adding those little tips of either it is because of pain or because of urgency or voiding always gives us a better idea as to what is going on.
Got it completely. Perfectly fine. Dr. Shobna, can we get you in to look at the discussion on the evaluation that we have done till now? So we did a urine routine, which was normal. The culture was sterile, apart from multiple urine routines and cultures in the past. Our ultrasonography overall, the lower tract, which includes her bladder wall thickness, her residual volumes, have been good enough. Clinically, when you examined her, you found there was deep pelvic tenderness, and your pain therapist also picked up some myofascial bands or areas which were looking at more spasm, something which has now been actually as a terminology in urology textbook in the latest edition of Campbell's Urology. So we're looking at patients do have it, which our pain therapists say, and our fingers not tuned to it, we miss out. The uroflowmetry was a bell-shaped curve at the age of 54 with a good Qmax and a minimal PVR, and she did not complain of obstructive voiding either. So as Dr. Tamil Selvi rightly said, there is this complaint about passing urine frequently and something which you'll pick up on a frequency volume chart as to what we will extract from the frequency volume chart. So Dr. Shobna, out here, we've got enough at this point in time for a woman who has been going through a stable but a progressive situation of discomfort, burning pain, pelvic discomfort. You did a clinical examination as Dr. Apul did want, and we did all that. Would you help us in the managing this patient right now with the wherewithal that we have on the information? Dr. Shobna.
I think with all these investigations, it's fairly clear that the other causes are all ruled out, like any gynecological, hardcore gynecological pathologies that can cause pain. They are all ruled out, and there is no infective pathology. There is no abnormal like overactive bladder or any other problem. So it points to interstitial cystitis. So I think the primary role of a gynecologist should be to be aware of how to diagnose interstitial cystitis based on these symptoms, because she's most often the primary care physician, and if some extra time is spent in history examination and all these investigations, I think that it will be very beneficial to the patient so that the diagnosis is not delayed and treatment is not delayed and quality of life improves. The second role of the gynecologist is to see if we have the luxury of liaising with the urologist always. We can refer and then just not refer and leave it at that. We have to keep the patient in the loop, follow her up, because we know this is a condition of flare-ups and remissions, and therefore we need to educate the patient about the treatment itself, about the condition itself, and to explain each and every treatment, tell her what we know at the moment about the evidence behind each treatment modality, what to expect, to be realistic in expectation about the treatment, symptom relief, and then what to do if there is a flare-up. Because treatment may work and then there can be a flare-up, and the same treatment may not work again, and who to contact, how to contact us. Rather than asking her to fix an appointment, we can have a timed review visits. Now, going on to the actual therapy itself, even if we are referring to a urologist, I think some form of pain relief will have to be initiated by the primary gynecologist. And we are all used to treating chronic pelvic pain with various pain modalities, starting from NSAIDs. Of course, for each drug, we need to find out whether there is any contraindication, whether there is side effect, whether it will suit the particular patient. So there are different modes of pain relief that we use, which can be initiated in her while she is waiting to see the urologist, or even as a primary treatment modality initiated by us, and she'll come back to us. The second thing that is showing on the evaluation is the myofascial bands. There is, we are becoming more and more aware of these conditions, which are very amenable for physical therapy by trained physiotherapists, which who help with, relaxation, stretching, and those kind of techniques, which help in these myofascial bands. And this should not be done by any physiotherapist. I think there are people who have specialized in this kind of therapy, and we need to liaise with them and refer appropriately to these specialists.
So I take home very wonderful points, and thank you so much. That's where my colleague gynecologists have joined in from all over the country and the world, and from Chennai, where this entire thing is emanating right now. To team up is very important. On one side, if I'm not a urogynecologist and I don't do it very regularly, I may get a help of a urologist looking at a different angle altogether. And that the relaxing the pelvic floor is such an important aspect around. And that's where the term comes, bladder pain syndrome. The entire definition is about the discomfort that somebody goes through in the region of the pelvis seems to be arising from the region of the bladder, That means there is this crossover all the times in the secondary neurons where bladder is to be blamed on that because there are sensations arising from the bladder. So Dr. Shyamla, we heard this very important yeah.
Can I add? I forgot to add the role of Kegel's exercises, because whenever it's a very commonly prescribed exercise by gynecologists, we tell patients after delivery to do routinely for life. But it is this is one particular condition, particularly when you have myofascial bands or any spasm of the pelvic floor muscles. This is something that we should not advise. In fact, it may worsen the condition, and therefore, what is opposite of this exercise, which is the pelvic relaxation, should be advised. That is also something that gynecologists should be aware of.
Agreed. So I'm glad you actually put that. So all in the audience actually take home this point that relaxing the pelvic floor will something be an active kind of a picture where we'll have to teach them the relaxation. They are always both mentally and physically going through. The lady at 54 is going through a massive agony. Remember, her past reports have all been normal. For anybody in the audience who wants to put a question to anybody of us, could actually leave some questions around while we are still on. We may have not had only 14 minutes plus or 16 minutes plus on the panel discussion. And we heard a lot of good points, which I'm impressed with. So Dr. Shyamla, was coming to you. The points that has already been raised are good enough. These points they stand tall in even our understanding and our guidelines that we follow today as urologists and are teaming up with our gynecologists in various cities, which we do now. Dr. Shyamla, do you want to look at aspects of treatment of this patient right now that she is on this? Her urine routine is normal. She has got everything looking normal and she is in discomfort. So are you into some kind of an inclusive kind of an understanding that she's going through something where there could be more add-ons that you want to look into? What she fits into what Dr. Shobna says that we need to be aware about this. What is your take on this? Because I will then come to Dr. Apul on something important.
So I think at this stage, we're going towards the bladder pain IC diagnosis, and therefore we have to have a look into the bladder lining in the way of cystoscopy, and basically to see whether there is, as the bladder is filling and emptying, refill, to see if there is any petechial hemorrhages or conglomerations or ulcers, what you call as Hunner's ulcers. And that will give us and rule out any other intravesical pathology. So if there is a need, biopsy is taken. And as we know, IC is diagnosis by exclusion. So if the other pathologies are ruled out and you have features of petechial hemorrhage or glomerations or ulcers, it is more towards interstitial cystitis. But we also know IC can have a normal cystoscopic finding. So either way, we'll have to go back to clinical acumen and treat accordingly.
So I've taken that. I took some important points. I'll go straight to Dr. Apul right now and ask him, sir, we have had this lady suffer for 5 years and she has been stable, but progressively in a situation where she has come with that first slide of burning pain, discomfort, myofascial bands, no UTI, thankfully. What is the timing for invading her? Do you advise urodynamics? Do you advise cystoscopy? At some point in time, now that we have got a colleague, Dr. Shobna, has started treating her already. What would be your timing of doing a cystoscopy if referred to you as Dr. Shobna referred it to you?
Okay, so I think it's a very important issue. There's some bit of confusion regarding cystoscopy. I think this confusion stems from the fact that cystoscopy is at two places. One during the diagnostic algorithm, and then again when we talk about cystoscopy for, and at the same time hydrodistension. And I think most of us, mix it up actually. We although they are separate, in the diagnostic algorithm, cystoscopy has a different value, and as a therapeutic modality, along with hydrodistension, it is another. So we need to, first of all, we need to consider these two procedures separately. At least, although we may combine in a practical scenario, we may combine, but when we are thinking, then we need to separate between the two. If you see the latest literature, now with the availability of flexible cystoscopy, so as madam said, so one reason for doing it's sort of, you don't mix hydrodistension at that time. It's simple, it's a simple cystoscopy. And although this patient, I'm not very sure, because some people will like to do it and others may not, and there's in different guidelines there's a bit of controversy, but still many people will like to do it because they like to diagnose Hunner's lesion type of IC, and the treatment, as they say, is slightly different. So you may do a cystoscopy. It can be a office cystoscopy at this time if you wish to do. And another point can be to rule out confusable diseases, for example, to rule out malignancy, tuberculosis, or something like that. So you may do a cystoscopy, but because this patient has a typical presentation, and then you may start, treatment straight away as well.
Wonderful.
So I think both lines of treatment can be followed.
Accepted. So Tamil Selvi, we need to tweet her forward from where Dr. Shobna had referred to Dr. Apul. So just looking at the patient jumped gun and did not go to Dr. Apul and came to you while she continued to have a discomfort around. Could you give us a little snapshot of some treatment modalities as a gynecologist we do across the country? What do we look at this now that we have looked at her as an IC bladder pain syndrome?
The first thing is, I'm going to counsel her. The first thing I tell her is, we are going to get this condition under control. I never say I, or we will give you some medication. I will always say we, and I usually say this. Long drawn process. So if you're looking for any quick fix, I'm not the patient you should be seeing. I'm not the doctor you should be seeing. We will be seeing each other minimum for the next 1 year. If you like me, maybe after that, but that is the time frame where you're going to actually look at each other, and we are going to tailor your management depending on what is happening. And that is my first statement, or all patients whom I actually suspect has got a bladder pain syndrome. Only then I actually carry on with the conversation. So if you're willing to make that commitment, then we will carry on from here. So with that, then we will look at the, as I already mentioned, the frequency volume chart or the bladder diary, what we call. I actually tailor it and I tell them, please do this and bring it back. And then I also tell them to list a few things. What makes it worse? Sometimes, as you mentioned, sometimes just sitting over there, sometimes sitting and watching TV for a long time, sometimes basically telling them, when I eat this, when I have a bowel movement, when I have, as we all know, this pelvic organ crosstalk is a major problem with bladder pain syndrome. So anything to do with bowel, anything to do with any other condition, that is the second thing I would want out of them. And third thing is what Neelanjana spoke to us. So the third thing will be all about what are the things which are triggering you, your fluid intake, what are you drinking, what you should avoid, how much are you drinking, how much should you be drinking, why you should not drink less, because your frequency is not going to get any better if you reduce your water. It is only going to get worse because you're going to get more pain. And that itself is a major thing for most of our patients to understand, to comprehend, that they have to actually drink more to reduce the frequency is something we need to make them understand. So those are the first three components of the counseling. Diet, fluid is the first thing. And obviously, if I send them home with this, they are not going to be happy. So actually give them painkillers. I usually start off with, I usually tell them, treat the pain and then get them on my side. So if their pain comes under control, then they are on my side. And I usually tell them it is not paracetamol. If you take it, your headache is go away. But if you take this, it's not going to go away. Don't stop the medication in 3 weeks' time. I'm going to see you back in the next 3 weeks, and you are going to tell me what happened in the last 3 days before you actually came to me. So I usually give them that time frame, and I tell them this is when you're going to look at your symptoms, not now. So that is how I plan the management.
Got
and
it.
from
Got
there on,
yeah.
then we go on to different types of drug therapy. And as Dr. Sir Apul Goyal mentioned, I wouldn't, in a typical patient like what you have mentioned, I wouldn't go in for cystoscopy at this point. Maybe after a while, after I've got the patient's symptoms under control, slightly under control. I wouldn't say under control. If the patient's symptoms are slightly better and they would like to come back and see me, then the reason I really want to have a look at that bladder is to rule out any other problem which could be presenting as bladder pain syndrome. And
Perfect.
as you know, tubercular cystitis is something which I also want to rule out in a patient like this.
Perfect.
So that might not be the first thing.
I got it, Dr. Tamiselvi. I wanted to come to Dr. Urmila for a while. Dr. Urmila, we heard Dr. Ratkal is here. Dr. Ratkal, thank you so much for that very important word which Dr. Tamiselvi did talk about. Reduce the stress, make friends with the patient, assurance that we will move forward, and then do that very important diagnostic and therapeutic algorithm in your mind as to, I'll continue treating going up the ladder, and obviously punctuate that with aspects of treatment which could be cystoscopy. So I will know more or less what my results came up over the next few days, few weeks, few months, and I will time, as Dr. Apul said, a cystoscopy which could be beneficial on umpteen aspects. And obviously we'll do a cystoscopy in a 5 years prolonged history to look at other aspects which everybody in the panel agrees to. But Urmila, are there medicines that you look at or a gynecologist looks at overall for the pain? Your tips on that, for the discomfort, for the burning? This is not a UTI. So burning pain in the introitus, which women complain and who have got pelvic discomfort kind of thing. Are there anything which you want to leave our colleagues with on, and regarding a cocktail which you would or gynecologist looks at in today's case, where one way is the urgency frequency related to the pain. The pain itself is the crux of the entire matter. And then there is issue all around which she is going through with myofascial bands. So Urmila, your crisp answer on this?
As Dr. Tamil Salvi said, we must first gain the confidence of the patient. We must really try to give her some relief. So talking to her, listening to her, let her feel that everything that she wanted has been said and we have understood it. I mean, proactive listening. And then we'll tell her about analgesics, relaxation, and diet. So
got it. So
and in this age group, we'll always try that local estrogen cream also.
Perfectly fine. Got it. So you are looking very holistic. You did use the word diet. So I mean, overall, when we look at, we may miss some points, but diet was important. Keeping the patient stress-free was very important. Giving them a chance that I would go forward. And as rightly said, we will take this forward, a journey to a different level. So it was only to enthuse my colleague gynecologists who actually are doing this subject already in ways more than one, to get into some aspects where colleagues who are already doing more than that are helping us out. And therefore, Dr. Apul Goyal was right in telling us that this patient deserves a very stepwise progressive approach. But Apul, before we come to this case, which I'll shorten up, you wanted to sum up the first case, telling us the way we treat these patients in short, looking at when do we proceed further and how do we take it forward as to what we grasp.
Okay, so Sanjay, I think it was discussed very well and all the points were brought out very well. And it was practically a very, very typical case that you gave, a typical age with the features of bladder pain, associated frequency that was explainable by the pain that the patient had. She had, bladder symptoms. The urine was didn't show any pus cells. The cultures were sterile. She had associated high tone pelvic floor dysfunction, which is fairly common in these patients. And there's a vicious circle between the two. The more the tension, the more the pain, and more the pain, more the high tone in the pelvis. We ruled out all the confusable diseases in the form of urine evaluation, voiding chart, ultrasound. And as I mentioned, you may or may not do cystoscopy. It depends on the institutional priority or maybe the physician's outlook regarding cystoscopy. Regarding treatment, I think as pointed out by panelists, we need to take the patient in confidence. There were three things actually in the history. If you see, she had pain, so of course you need to take care of pain. She had associated voiding symptoms in the form of urgency, frequency. You may or may not start anticholinergics. And the third issue was regarding the high tone pelvic floor dysfunction. So you need
Dr. Apul, can I just interrupt you? Dr. Rajarajan has actually asked us, please mention the pain relief medication, the dose and the duration as the steps of treatment. So those three important points. The anticholinergic to give her that relief in a background of a good flow, number one, because it's pain. Number two, the pain relief medication for the myofascial bands and the deep pelvic pain which is arising. And number three, the entire holistic nature of managing. Could you just give us some idea on the name of the medicine and possibly the dosage to start with, just to give a start to head-on?
Okay, so anti-muscarinics, you can start with, there are n number of molecules that are available now, anti-muscarinics, or you may choose a beta-3 agonist as well, depending on the age and you can and the the age of the patient primarily. Solifenacin is a good choice. You can start with amitriptyline without starting anti-muscarinic. Amitriptyline has multiple.
Did we lose Dr. Apul Goyal?
It looks like that. It looks like
Dr. Apul, go ahead.
Yeah, audible. Okay. So, so it might, only this drug may have, and combined with treatment of high tone pelvic floor dysfunction, I think these two modalities, you may alkalinize the urine, all those things, warm sitz bath and things like that. Along with that, I think the patient will start having relief. For pain, for pain, you may start with gabapentin.
Yeah.
Or you may, just hold on at this moment, see the response of these drugs, and then maybe if the patient is not relieved, with all the physical therapy, sitz bath, dietary modifications, and the therapies that we discussed, then maybe later on you can start that.
Got it. So completely fine. I think I've got what I wanted. So Dr. Rajarajan, for you and for the audience, we heard on one side that the patient doesn't have obstructive voiding symptoms. We could get into either a solifenacin or mirabagon, one of them. Watching that, we are going to watch patient closely on the bladder's overactivity. But remember, this bladder is not grossly overactive. It is pain-related situation where at some point a cystoscopy ruled out that there is no lesion, no carcinoma in situ, no nothing, and the bladder capacity being good. It is all that her pain was giving her the issue. We go to pain relief. And we heard rightly that pregabalin and gabapentin in the right dosages, which to us starts pregabalin 25 to 50 milligram as a very basic dose and go up the ladder. So you don't give them the side effects, the effects which you don't look at. Remember, we actually induce sleep in few of them by giving gabapentin and pregabalin at night. And they get a better sleep at night, which is only short lasting. It doesn't last long time. On one aspect, we do that. That also helps in the pelvic floor, muscle pain. They feel better around. Amitriptyline is something which actually adds on to such an important so-called cross sensitization and central sensitization and helps you a lot on the pain relief. So one drug may not do a business for all of us. So on one side, we had heard also NSAIDs, which could be given on a short term. But we're looking at long-term therapy. We are going to delve into a situation where patient comes back either 2 weeks or 4 weeks, and you would look at how to counsel patients who have to come back. So there are two ways to counsel patients who come back. You could tell them, please come in 4 to 6 weeks time. Tell them if SOS requirement, come earlier. And you will find that the patient came in 3 months time or the patient came in 2 weeks time. So you know what does 2 weeks mean and what does 3 months mean. If the patient continued medicines on 3 weeks because you had said medicine should continue, then I think you've already gone to a level where you have got her on a relief level. Other things is what scientifically you will do to look at match and mismatch issues around. But she comes back in 2 weeks' time, is you may have to do escalating dosages and dosages which will be required to move forward. So obviously, on one side, as Dr. Ratkal said, decreasing the stress. On the other side, we knew that there is no specific food that we are aiming at. Patient notes the food diary and we pick up the food diary from the patient and understand that in different geographic areas in this country and abroad, we've got patients who miss out few things. But other than that, what we had heard from Dr. Nilanjana ji was a large picture of patients telling us, and we should believe that many things diet could get into. And therefore also don't forget that IBS and bladder pain syndrome do coexist. Very important. Again, it's related a lot to the kind of food activity going on and the kind of dissolution and the metabolic activity, but both of them could have a similar genesis or a similar progression. So I would actually look at stopping this case here and run through a case which is a pet case to me, which would add more meaning before we come to a close, because I will take final answers from each of you on this case. I would not ask you anything on the case to start with. This is a pet case to me, but we've just labeled her that she comes from Manapakam in your area. She's young, 41. She has a discomfort which is more suprapubic. So it's not only the burning introital which you saw, but she has a suprapubic discomfort all the time. Intermittent exacerbations of this. So she's not a stable pace, progressive like the 54 years young lady, but she is something. She has got increased frequency of urination. So she has frequency. She was treated for an episode of UTI recently 4 months ago in the lockdown. She has regular menstrual periods. Not a reason for her to go to a gynecologist, but remember, women go to doctors who treat perineum and pelvis better than urologists, and they are all gynecologists. So you hail doing a lot of work in the pelvis on lot many organs now, including the bladder pain syndrome and the pelvic region. She carries an ultrasound report of that time when the UTI episode happened, which broadly is normal. A urine routine has few pus cells and a culture is sterile. So this is a presentation. Just to tell you that the presentation 4 months after a symptomatic UTI which she was treated with, and she's only 41. Let me just move forward and tell you what questions you could have had. So you have told me this, and that's why for the audience, all that we looked at the duration of discomfort into her months or years, and she had exacerbations each time. So there could be reasons of exacerbation. Relief was seeing a gynecologist and a urologist and taking the right medication. One episode of UTI, you took each of the important points in history, right from hygiene, sexual activity, obstructing, strangury and all that, and that holds a lot of importance. Is it in background of a completely normal flow? And then you look at her frequency, which is grossly frequent around. So you wake up that the UTI dissolved and disappeared completely from the face of the earth 4 months later. Now she comes back with symptoms which are as bad as it was suprapubic, introital, continues to have those symptoms at 41. And her baseline lower tract is all good. Her uroflow is good. So if I look at the larger picture, she is exacerbated by coitus. She has forced frequency. And rightly said, she is specifically avoiding food which has caused her trouble, more of citrus, more of dark chocolates, and she gets her own relief. She has learned her relief by going to the toilet, etc., etc. So we did talk about this very important aspect of history and geography. The geography is about examining and looking at, she doesn't have the vulvodynia, vestibulitis, and possibly more than what we have picked up is to rule out anything clinically. The expectations was that. And then came ruling out these. And that is where you all did talk about that she had just one episode of symptomatic UTI. She speaks loud and clear. She does not have endometriosis, very clearly visible. Her menstrual periods have occurred. She has been a mother. She is not a case of overactive bladder. These are the first diagnoses which come. We heard the word from Dr. Shamla, inclusive plus exclusive. One way we would exclude everything, but our mind will go into including things around. So we move forward and look at her warding diary of 3 days, which could even be 1 day, as Dr. Apul said, which gives us an idea about what. We look at her evaluation, nothing significant on these evaluations. So you have ruled out all those aspects which was looked at. So UTI did not come second time. Those her problems continued without an exacerbation this time. And her past is about getting treated and being on a baseline. Therefore, she has learned that she won't go to doctors on very basics around. But she continues to have stable symptoms and her agony has not gone. So this is not a UTI this time. Dr. Shamla, this patient is much younger. She's 15 years younger to the last patient. So in very quick, could you tell us how does this look like compared to the past one, where we had actually look at 54s, vaginal atrophy, changes happening in the pelvis and perineum. She's much younger. She has only one episode of UTI. Her suprapubic is in discomfort. Her days and nights are quite frequent, 14, 15 times a day. And she continues to have agony even in the perineum and pelvis. So suprapubic discomfort, force urgency, and quite a frequent urination. Does he need a little quick warrant into an active and a progressive kind of a care?
There's also a mention about her dietary intake, which is an aggravating factor. Apart from that, I would think whether there is a role for, because having had all these medications, having been treated and with symptoms of OAB, is there a role for urodynamics before we proceed? Because she's had all medications. She's had medications mentioned before, like amitriptyline or gabapentin. And in spite of that, she's having frequency urgency. Then I would think in the absence of urinary tract infection and having had physiotherapy, go back on her diet, because that seems to be an aggravating point in that one of the slides, and see if that improves. If it doesn't, then is there a role for cystoscopy and urodynamics?
Yeah, so something like that. But Dr. Apul, would you like to treat the frequency per se? She has a frequency urgency. Would you like to treat her on that aspect?
No, the frequency as usually in these patients are because of pain. So if you treat the pain, I think the frequency will be relieved.
Yeah, perfectly fine. Dr. Tamil Selvi, what is the pain relief you're going to give her to reduce her frequency?
To reduce your frequency, so basically I would give a combination of possibly amitriptyline and an anticholinergic as well if needed. So
give me the dosage. Dr. Rajarajan wants to know the dosage.
25 milligram. I usually start off with bladder pain syndrome, amitriptyline 25 milligram at night. So that basically will help them a lot. And solifenacin would be the drug of choice if I'm going to use an anticholinergic. And more importantly will be I will tell them, just don't look at the solifenacin 5 milligram, by the way. I wanted to add on the dose. I usually tell my patients, don't just look at the front of the prescription, because I'm going to write instructions behind the prescription. So where I will mention all about this fluid advice and dietary manipulation. So both front and back of your prescription is important. So that will be the first line of management for this patient. Fluid advice, dietary advice, pain relief with amitriptyline, and add an anticholinergic.
Completely fine. I think I'm completely happy to look at that. So I'm just going back to the first situation right now. With all that we have got on this, she's living with this around. She has no UTI other than one documented UTI. Now also we evaluated her, we had no UTI. Dr. Shobna, Dr. Tamil Selvi agreed that she will look at two aspects. There's a combination, a vicious cycle of things happening around. She looked at one side, she will treat her pain, and she will treat a pain-related frequency. That's what Apul Goel wanted. With these two done around, she may be good enough. Her suprapubic may be good, her burning introital pain would be good. You did already talk about teamwork and using a physiatrist, a pain therapist, a urologist. What else could be missing in this case at this point in time? Though we may move further, is there anything else which you wanted to add around and look at? We could get her much comfortable that everybody doesn't require a cystoscopy.
You did ask what pain relief we would start as gynecologists. Wanted to add, we do treat chronic pelvic pain with SSRIs and a combination of tramadol, paracetamol. So if I were to start her on something, I would start on that. And I think the one point that we didn't discuss is the psychological assessment also, because we have a lot of gynecological conditions where we do a psychological assessment. It does affect the quality of life, not only as a one-point assessment, but later on to see the response to treatment and all of that. Apart from that, I'm just looking at, apart from ruling out vulvodynia and vulvovaginitis, cervicitis, and other problems, I'm not. I think
should be fine. Should be okay. I've got it, because the only issue now is left over in between a question that Dr. Apul, Dr. Shamla did talk about urodynamics at some point for frequency. Now, Dr. Tamil Selvi talked about treating the pain and frequency together. where does urodynamics, Dr. Apul, come into this entire picture on patients with bladder pain syndrome? When would you look at giving them a kind of a test which could be more uncomfortable, or when does in the lineage? Could you just give a little idea on the urodynamics, Dr. Apul?
Okay, so urodynamics typically tells us about bladder function and as regards sensory and as well as the motor aspects. So typically in patients with interstitial cystitis, bladder pain syndrome, it has very limited role. The overactive component, if you see the series where urodynamics has been done in these women, so overactivity has been documented in about 14-15% of patients, which is fairly similar to what you see in the general population also. Okay, so but it does tell you about even for the thing that you come to know on urodynamics is probably bladder capacity. But I think a better evaluation would be avoiding diary. So the role of urodynamics is quite limited. You do it only when there is confusion, there's some, you are not clear, the patient is not responding, and probably you have reached end of the road and you think maybe it tells you something that you are probably missing till now, and that may be the role of urodynamics. But otherwise, in general treatment and general management, typically it is not recommended strongly.
So in added voiding dysfunction, stress incontinence, where you may add on to something in something which is not getting managed and you attempted to treat, I think these are important aspects around. Can I have or the panel answer me this? What are the specific foods that which actually increase the symptoms apart from having those citrus fruits and caffeinated drinks which irritate the bladder on one side? The bladder is irritated with a disease and the lining or the wall and pancystitis. Therefore, the irritation of the bladder, Dr. Gina Baburaj, all those food which would irritate the bladder and irritate the bowel too, in that IC bladder pain syndrome, IBS, PPS activity, which are basically the caffeinated drinks, the dark chocolates, very clearly, the citrus fruits, many of them avoid around. Is there anything which you want to take home from Dr. Nilanjana's talk and give us names of something which Dr. Tamil Selvi in that part of the world, between idli and dosa, what is that they avoid and tell, I don't eat this and I don't eat that?
Most commonly, what I do notice is patients usually say, if I eat spicy foods, and you do know that patients in Tamil Nadu and Andhra do eat a lot of spicy food. So they do actually say, when I eat spicy foods, it gets very worse. And I also think it is not the spicy food per se. The spicy food does affect the gut to a significant extent.
Absolutely.
And
Absolutely.
because of the gut involvement, I think there is a crosstalk between the nerve sensations between the gut and the bladder. And that is what triggers the bladder pain. So usually when you go back to their history and you ask them, they usually say, yes, when I eat spicy foods, I not only have a problem with the bladder, I also have a problem with the bowel. So then you know what exactly is happening. So that is one group I usually consistently notice is spicy foods.
Got it. So very rightly, as Dr. Shyamla had said, cystoscopy can also be normal in such patients around, but this still could be bladder pain syndrome. And you actually did nail it. You did say that the entire thing about the viscera, which is the colon, the rectum, the bladder, and the bowel, and the other aspects which are going to be the perineum and the gluteus and anal verge, etc. They all have collation of their noxious stimuli and organs which fill up, which are the bowel and the bladder. The filling up gives discomfort. It's something which arises to call us as bladder discomfort. So out here, Dr. Apul, could you take us through the management of this patient or management of a cystoscopic picture of this very patient as we do a cystoscopy? Could you take us through with this cystoscopy if it's visible to you?
Yeah, it's very much visible. I can see the bladder neck. Yeah, I'm inside the urinary bladder, and okay. Yeah, here on the left side of the view. Yeah, now you can see clearly a stellate shaped. I think this is a Hunner lesion, a typical Hunner's lesion. So with the central pink area. Here is the urethral orifice.
You see a second Hannah's lesion there.
Yeah, a second lesion there. Now there is also a role of this technology where you can improve the contrast. You have the blue light cystoscopy.
Yeah.
So that can be. So this is, I think, a typical view, and as pointed out by many colleagues, cystoscopy may be entirely normal. So that is one reason people sort of avoid, and you need to tell the patient that it is primarily to rule out other confusable diseases. Okay, because the chances are that the cystoscopy may be entirely normal, absolutely normal.
Got it. Completely got it. So, Dr. Apul, how do I manage this on the table under general anesthesia? I've got this patient, and Dr. Shobna and you both are in theatre. And Dr. Shobna said, "Why don't you go ahead, Dr. Apul, and manage this patient?" So, what does it look like on the operating table? What are we doing to her apart from cystoscopy?
Okay. So, Sanjay, there are many options. I'll not say there's a standard protocol.
Yeah. Just give us the options.
Yeah. So people have fulgurated it. Some have resected it also. So, but let me caution that if you resect, the bladders are thin, so you may make a perforation in the urinary bladder and complicate matters. So fulguration is one option. And people have injected steroids, triamcinolone injections. So to my mind, these three options in the first go are, you can choose between the two, between all these options. So that would be my opinion.
Completely fine. So there are, once you are, that's the reason why we were at some point in a general anesthesia. We're looking at how to take it forward. Dr. Tamil Selvi, you want to add something out here?
Well, with the
all the literature that you read, they have clubbed the entire thing together. And I think anyone who's treating this condition, they need to fine tune and try to differentiate between the two and manage accordingly, rather than starting with first line, second line, third line, and all that.
Completely
So
fine.
that is what
Completely. Wonderful.
I
Wonderful. Thank you, Dr. Apul. Thank you so much for being there. Dr. Shobna, your last sentences, please.
I think gynecologists need to be more and more aware of this condition, because they are going to see patients coming with symptoms. They may be the first ones to see these symptoms. And secondly, rather than thinking of it as a diagnosis of exclusion, I think in a positive way, we should diagnose this based on certain specific symptoms, and that will increase the diagnostic accuracy, and will not miss the diagnosis. And as gynecologists, handhold them throughout their journey of their treatment. Even though they have a multidisciplinary approach, I think primarily we should make them feel that we are there for them, and then guide them at every step, invasive, non-invasive, flare-ups, and remissions and exacerbations. Throughout the journey, we need to be traveling along with them.
Got it. So you are singing the tune of Gibbs where we talk about inclusive definition. I didn't bring it today, but very, very music to my ears that, we are so impressed when leaders speak this language. It's very important to be inclusive. Look at the positives you can draw from the history examination and take home from all that is there in the kitty of those thick files the patient carries. Wonderful. Dr. Shyamla, your last sentences, please. Wonderful to have you on board.
It's a complex condition. Patients are psychosomatically involved in a huge way. We need to counsel, we need to have the patients, we need to go step by step, involve the multidisciplinary team, and then take it forward with concentration also on the dietary aspect of this condition to get the relieving factors.
Thank you so much, Dr. Shyamla. It was nice to have you all three from Chennai. Before I give it to Dr. Tamil Selvi, can I request Dr. Urmila to, because she has taken the subject over the last 5 years of our partnership to very high levels in that part of the world. Dr. Urmila ji, can I have your last sentences on this wonderful panel discussion people have covered?
We are the conduits through whom the patients will be benefited. And this has been a really enlightening lecture. And I'm happy that we gynecologists, we should first be aware of this condition, and we should know our limits, and we should know when to refer and keep the patient in follow-up. So I'm
so nice. So nice. So nice. We're very, very impressed with what we did today. Dr. Tamil Selvi, your last words. We have kept Dr. Geeta on hold for so long. So after you have spoken, Dr. Geeta will take up the final vote of thanks.
Thank you. Now, we are talking about inclusion, Dr. Pandey. I think when we are talking about inclusion, we are including the patient in the treatment, but there's someone else we are forgetting, the patient's relative. Because for a long time, they have actually come together with them and they've had all investigations, and all investigations have been sort of normal or near normal. And the patient has been labeled as it's in your mind, which is what we normally hear. It is in your mind, and that is what, because no one has found anything. So at the initial part of the management, we need to involve a family member and actually make them aware it is not in the mind, it is basically in the patient's nerve endings. There is a problem. There is an organic problem, and that needs to be managed. So this is very common theme which we need to address across all patients with chronic pelvic pain, and more so in painful bladder syndrome. And we need to take that, because once the patient's relative, the attender, comes to know there is a problem, then they will get a positive feedback. But if you tell them, call them, I will tell them it won't work. So the way you need to tell them is, the patient is under a lot of stress. So the patient might not remember whatever I tell them. So you please listen to me as well. And then you can go and reiterate to the patient. So then you bring on another partner in your management plan. So I think that is very ideal to do that management. And the management plan, there is a common theme, diet, fluid for every patient. And as Dr. Apul Goyal mentioned, for each patient, the next line of management varies depending on what their symptomatology is. You tailor the treatment to the patient and not give the patient any treatment which you think is the right thing because the last patient benefited from it. That will be my last words. Thank you.
Cheshta, take over and
Yes, sir. Thank you, panel, and thank you, Dr. Pandit, for having such a wonderful session. Now I would like to invite Dr. Geeta for giving a vote of thanks. She is consultant obstetrician and gynecologist and fertility specialist at Institute of Reproductive Medicine, Madras Medical Mission Hospital, Chennai. Welcome, ma'am. Over to you.
Good evening, everyone. I take this opportunity to thank everyone today. This was a very interesting and extremely, what to say, excellent discussion on this enigmatic disease, bladder pain syndrome. To start with, I should thank Nilanjana ma'am about your elaborated talk on diet and its importance for BPS. And we are happy that we can refer your book for our patients as well, ma'am. And congratulations on your work, madam. I should thank you, sir, Dr. Sanjay Pandey, for your great panel discussion with interesting scenarios. And I'm happy that panelists have also impressed you with their discussions. And we had very nice take-home messages from each and every panelist, which was very, very useful for us. And other than the academic discussions, we also grabbed some take-home messages of listening more to patient, talking to patient, and making friends with patient. And I would like to thank all speakers, delegates, and panelists who got this program live. And special thanks to Swati Spento's team, and especially to Chesta and Deepthi for getting this event a grand success. Thank you, everyone, and hope to see you all again soon.
Rambo Santoshma, very good. Just
Thank
impressed.
you, everyone. I would like to take this opportunity to wish you all a very happy new year. We will be starting a new year, hopefully with all new beginnings with COVID behind us. So happy new year to all of you.
Thank you, everybody. Thank you and bye.
Thank you.
Yeah.
Thank you.